Good morning, everyone. On behalf of International Bipolar Foundation, I would like to introduce today's speaker, Dr. Louisa Sylvia. Cardiovascular disease is the leading cause of morbidity and mortality among individuals with bipolar disorder. Diabetes, hypertension, hyperlipidemia, and obesity are among the most common diseases in bipolar disorder and are also the leading risk factors for cardiovascular disease. This medical burden is highlighted by individuals with bipolar disorder having nearly 3 times more medical admissions than other behavioral health care diagnoses. Although it is unclear why the medical burden in bipolar disorder is so high, it is a primary concern for the treatment of the disease. Dr. Sylvia will discuss this medical burden, its importance in managing bipolar disorder, and ways to overcome it. Specifically, she has developed a therapy called NewTX, which is composed of the following treatment modules: nutrition, weight loss, exercise, and wellness treatment. Today, she will review the rationale for this therapy as well as ways that you can start doing some of the strategies to begin a healthier lifestyle. Dr. Sylvia is a staff psychologist and is Associate Director of Psychology at Bipolar Clinic and Research Program at Massachusetts General Hospital. She is an assistant professor at Harvard Medical School and is the director of clinical operations of the Bipolar Trials Network. She is a trained cognitive behavioral therapist and maintains an active caseload of individuals with bipolar disorder. Thank you so much for joining us today, Dr. Sylvia, and welcome.
Excellent. Thank you so much, Debbie, for that great introduction. Again, thank you all for attending as well. I understand we have quite a group spanning near and far. So I'm in Boston, but I think we have folks calling in from all over. So thank you for your time today. And really, this is a selfish talk on my behalf because I really hope all of you listening in will give me some feedback on this treatment that I've developed. We're still in the early phases of developing it, and I'm really looking to hear something from each of you out there about what works for you getting to wellness and what may be your struggles. What are some of your challenges as it relates to getting to wellness? So again, thank you all for calling in, and I really do hope to sort of wrap up a little before maybe around 1:15 or 20:01 so that we have 10 or 15 minutes to take some questions and comments from the folks on the call. So thanks again. So without further ado, I'll get into talking a bit about getting to wellness. First, I do want to just mention my disclosures. So I do have research funding from NIMH and the American Foundation of Suicide Prevention. I also have royalties from New Harbinger for the 2 books that are listed there, the Bipolar Workbook and the Complete Wellness Book for Bipolar Disorder. The Bipolar 2 workbook is out. If you do have Bipolar 2 disorder, please check it out. And the other one will be out next year. And I also serve as a consultant as well for several different groups that are listed there. All right, so first, what is a healthy lifestyle? I get this all the time. What does it mean to sort of be feeling well? And I think that's really a question that's very individualized. But if you look at what the internet says, it talks really about protecting your mind, body, and spirit. And that's really, I think, a nice summary of what I tried to do with this nutrition, exercise, and wellness treatment was to approach healthy lifestyle in a variety of ways, not just necessarily about nutrition and exercise, but also as it relates to sleep, substance use, getting support from others, and a variety of other ways. So I think keeping that in mind, that we're really talking about a lot of different things here, not necessarily just nutrition and exercise. Okay. So I'm going to go through a little bit of the background on sort of the rationale for this. Debbie already in her introduction gave a little bit of sort of why we need to maybe be focusing on this as it relates to thinking about bipolar disorder. But I actually just want to start with some general information that's out there for the general population. So maybe not surprising, maybe a lot of you on this call already know that people generally don't eat very well. And most of my stats are going to be as it relates to the United States population. But and we are an unhealthy group, unfortunately, and there are a lot of other cultures that are doing better than us. But you know, overall, we struggle with this. People tend to have too much fats and sugars, and particularly refined grains. We're way high in our sodium intake and saturated fat intake. And in general, we're just not eating some of the basic things that we really need to be eating, which I call our naked foods, our raw foods that come right out of the ground, our vegetables and our fruits. We really need to be increasing those. And as a result, if we were eating healthy, we would really see some positive physical health benefits. I'll talk about the mental health benefits in a minute, but we know that if we were eating better, that it would absolutely help our cholesterol, our blood pressure, and our risk for developing obesity, and may even prevent, I think this is pretty powerful stuff, may even prevent cancer, heart disease, and stroke. So just again, as I said, it's going to be a lot of US stats, but I do want to show this just to give you a sense. If you're in one of those orange states, beware, you may be in a culture that's particularly at risk for developing obesity, although you can see sort of across the board that that the United States struggles with obesity. Having a quarter of the population obese is noteworthy. There was, back in 2012, they really tried to, the CDC really tried to see if we could get all the states underneath 12% rate of obesity. As you can tell, we did not hit that. So we still really struggle with managing obesity in the United States. How about physical activity? Well, you may not be too surprised to know, too, that physical activity is not great here in the States as well. About a quarter of us really aren't doing anything. And again, it may not come as a surprise to you guys that by not doing anything, and as it relates to physical activity, really can increase the risk of us all a whole host of cardiovascular issues as it relates to obesity, hypertension, diabetes, etc. And that obviously translates into a very expensive problem for our healthcare. And again, you'll see, probably not surprising, the darker blue, right in that same area where our obesity was, is exactly where we're having our inactive folks for the most part. But again, you'll see that unfortunately these blues spread all across the United States here, and it really highlights sort of the prevalence of inactivity across our country. And last but not least, as I said, this wellness module was really developed to be very personalized and to sort of pick up on areas of healthy living that folks in the treatment may not have. And it could really be, some people may struggle with sleep, some people may struggle with substance use or stress management. So we really try and kind of pick which of these areas and focus on that towards the end of the treatment to help folks kind of really get that whole picture of healthy living, if you will. So the wellness module is a little more flexible than the first two modules on nutrition and exercise. And I think this was amazing. Again, this is a United States group, but look at the percentage of people who unintentionally fell asleep at least once in the past month. That's amazing to me. That you're looking at 30 to 45% of folks fall asleep at some point unintentionally, and that's pretty amazing. And then obviously you can see lower percentages, but still, percentages to take note of, because these are folks who are falling asleep while driving, and it's about 2% to 7 or 8%. So again, certainly speaks to how sleep is really important. Again, right now I'm talking general population stuff, but and then we'll focus in on the bipolar pieces in a minute. But want to point out how this is an issue across the board. And I think this is also amazing. Now this graph shows just alcohol and drug use, okay? So these are people who are just drinking. It's not maybe a problem for them. So again, these aren't abusers necessarily, but look how high just the use is. And I think this points to, again, how much this is part of our culture. You're looking at almost 90% of people drinking alcohol at some point in their lifetime. And then the numbers drop off slightly for the past year and the past month. But that's astonishing to me that we're in a culture where just about everybody is using some sort of alcohol. So imagine that. I think that speaks to how difficult it is to make changes as it relates to your drinking behavior, because a lot of people are doing it around you. And you can also see the rates for tobacco. Now, this is a little bit outdated. I tried to look for more recent numbers. This is from 1999, and I apologize. So it's 15 years old now, but because I do think tobacco has gotten a little bit better. But do note that, again, tobacco is still high, marijuana, and so on. So again, it speaks to how these are issues across the board for individuals. And last but not least, I thought this was a very interesting statistic. So these are days away from work due to anxiety, stress, and neuroticism. And you'll see that when you're over the age of 30, when you've had greater, the percentage of folks who've had more than 30 days away from work, it's high. You're looking at 42% of those folks who have anxiety or stress and neurotic disorders are experiencing at least 30 days away from work due to feeling anxiety and stress. And that's a lot of people. So again, I think this is just a graph that shows really how prevalent anxiety and stress is as it relates to our functioning. All right, so now getting back to what Deb was saying in the introduction, how does this relate specifically for bipolar disorder? And I wish I could say that the news was better for folks who have bipolar disorder, but it looks like that folks with bipolar disorder may be at increased risk, even more so than the general population, for these issues. We're not entirely sure why. There's probably a whole host of reasons, some of it being genetic, some of it being as a part of the actual disorder itself, and probably also as it relates to the treatment. As many of you probably know on this call, a lot of the medications used to treat bipolar disorder unfortunately have some negative side effects as it relates to things like changing appetite and fatigue, and that impacts your eating behavior and your activity behavior, obviously. So the bottom line is that there looks to be an increased medical burden or more medical complications in bipolar disorder than the general population. So this really worried us, and it worried the National Institute of Mental Health, which is a big funding agency here in the States, so much so that that's why they funded me to do the work that I'm about to talk with you guys about today. And that really is developing this psychosocial intervention. So again, I'm a psychologist, so I don't do medications, I do therapy. And I developed this nutrition, exercise, and wellness therapy, and as Debbie mentioned at the outset, with a lot of cognitive behavioral therapy. So I'm a trained cognitive behavioral therapy, or CBT, clinician, and so a lot of this manual is based on sort of CBT principles to help people make changes in their eating, exercise, and wellness. And I'll walk through a few of those different strategies today. But first, again, I want to talk about the literature as it relates specifically to bipolar disorder. So now when we look at how are folks with bipolar disorder really doing with eating, and it's worse, unfortunately, and I think it's because of a couple reasons. One, I think when you have a mood disorder, you're much less likely to want to go to the grocery store and cook. And as a result, that can be tricky to eat healthy, because now you're relying on eating out, a lot of fast food places, because that's cheaper, which is another obstacle, right? Money. It's always nice to just grab something on the way home or grab something at the convenience store. But as you know, those places are not the best places to get healthy foods. So there's a lot of relying on unhealthy prepackaged or prepared foods, which results in not having the essential vitamins, minerals, and things like omega-3, which we think may be a mineral that may be particularly helpful in managing mood disorders. So unfortunately, obesity is slightly higher in serious mental illness, bipolar disorder, than it is in the general population. And the same goes for exercise. It looks like, again, we have mostly sedentary lifestyle in folks that have bipolar disorder, and as a result, that leads to increased morbidity and mortality. So to be honest, you're at increase. If you have bipolar disorder, you're more likely to have physical health complications as a result to your lack of exercise and eating habits than something related to the bipolar disorder itself. So this is really a big issue, and points to the fact that, I can't tell you how many people I work with who say, come on, Dr. Sylvia, I have bipolar disorder. How am I supposed to eat well and exercise and do all these other things? And I go, I know, it's a lot. It's a lot to worry about and think about. But this type of stuff is almost, I don't want to say more important, but it's certainly as important as managing the mood episodes and thinking about those other things, because exercise and eating well also has mental health benefits. And last but not least, you can probably understand if you have bipolar disorder that you're at increased risk for making what I call unhealthy lifestyle choices. And that's in large part because a symptom of bipolar disorder is impulsivity, specifically as it relates to feeling elevated. And therefore, when you're feeling impulsive, you're going to tend to do things that may not be in your best interest, like eating foods that aren't great, or using substances, or not exercising, or those kinds of things. So making good, healthy lifestyle choices can be a challenge. We certainly want to talk about that. And you probably have heard some of the literature on how important routine is for individuals with bipolar disorder. There's been a lot of literature that suggests that if you have good, we call circadian rhythm regularity, so that's a good daily schedule or routine, that you're more likely to prevent future episodes, that it will help to sort of buffer against future episodes. So having a regular routine, and the big components to having a regular routine are exercise, sleep, and your meals. So having a good wake-up time and going to bed time and having a regular meal time and regular exercise time, those are all very important components to having a regular schedule or a good circadian rhythm regularity. So again, these are components that we talk about in the wellness module to help other areas of wellness outside just of exercise and nutrition. All right, but let me give you a little bit of an overview of what we do in each of these modules. So the first, this is a 18-session, 20-week intervention. So it's long. People say, come on, I can't do this for 5 months. And I'll say, well, you know, the evidence shows that we need time to make changes in your physical health. We need time to make these changes so that we can see better cholesterol and lipids, and we can see your blood pressure get better. So it does take, you know, quite a bit of time and to do this. You know, we need time to be able to sort of see these happen. So the first 6 sessions are really focused on the nutrition module, and there's 2 goals with this module. The first is improving nutrition, and I'll talk more about this Harvard food plate. It's not very different than the USDA, United States Department of Agricultural food plate. The only difference is that the Harvard food plate talks about the importance of drinking water opposed to milk. That's really the biggest difference. So the Harvard food plate is one that I follow and we'll talk quite a bit about in my bipolar wellness book when it comes out next year. The other thing we talk about in this module is teaching serving sizes and portion control, as well as discussing the importance of certain vitamins and minerals. And the other part of this first 6 sessions of this module is promoting weight loss. And that talks about, you know, monitoring your weight, making sure that we're looking at obstacles to losing weight. I caution people, though, I can't tell you how many people come to me and say, you know, I really want to lose weight. And I caution people to make that their main goal. And the reason is because weight loss can be very frustrating, right? It doesn't happen right away. You can have weeks where you stay the same. You can have weeks where you maybe weigh in a pound heavier because you've had some more water, or you're having your menstrual cycle, and therefore you're going to be retaining more water, and so on and so forth. And so people can get discouraged easily when you focus on weight loss as being the main goal. So as it relates to wellness. So I try to tell people to focus on other areas of wellness when it comes to setting your goals. Not to say that weight loss isn't important. It is really important, and it's certainly related to good, healthy living, having lower weight. But you know, just to caution you to make that sort of your main goal. But we do certainly talk about this in this intervention. I just try not to sort of emphasize it as being a main goal. You will lose, I tell people, you will lose weight if you make healthy choices and you stay to sort of trying to live a healthy lifestyle. The weight will come off. We don't have to worry about making that a primary goal. All right. The second module of the exercise module starts around session 7 and also goes for about 5 or 6 sessions and focuses on psychoeducation, so the importance of exercise not only in improving your risk factors for cardiovascular disease, so not only with things like, you know, improving your lipids, your cholesterol, your obesity levels, but also as it relates to improving mood. A lot of you may have heard on this call already that there's been some very good studies that have shown that exercise can actually act as an antidepressant and really help lift depressive symptoms. And so therefore there's a great reason to be exercising if you have bipolar disorder. But again, we talk about, you know, what does exercise look for you? What's your history as it relates to exercising? What have you done in the past? What seems sort of a reasonable place for you to start now and to build up? So we really try to make it a personalized intervention for you. But we do try to get to what we call the gold standard of exercise, which is exercising 30 minutes at least 5 days a week. Okay, so that's sort of what we hope to get folks to doing. Some people may go beyond that, but we're really looking for kind of a minimum of getting 30 minutes 5 days a week for most adults. Okay. And as I said, the last module is sort of focused on at the end, so the last 5 sessions or so, 4 or 5 sessions. And this really focuses on using cognitive behavioral therapy and MI, or motivational interviewing, to help make healthy decisions. And that's, you know, making healthy decisions as it relates to food choices and exercising, but also as it relates to these other areas of wellness. So again, social and structural support, Again, not being impulsive as it relates to spending, using substances, and smoking. But let me talk to you specifically for you, those of you who are on the call. I want to make sure that I cover some ways in which we do actually do this in the intervention, so that you may be able to do this on your own at home. So the first thing I do is we talk about nutrition and exercise, and as I sort of already mentioned, and how those eating well and exercising can help improve mood. We also talk about the impact of psychotropic medications. Here's the good news. Well, let me start with the bad news first. So the bad news is that yes, psychotropic medications, particularly some antipsychotics, can alter your set point as it relates to your appetite. So it can make you have more food cravings and feel hungrier, which can lead to eating more, which can lead to obesity. Here's the good news. You can still lose weight while taking psychotropic medications. Okay, so it's not that the medications just add on pounds, it's that the medications are just another thing that we have to, it's another thing that makes it harder to eat well. So we just have to work harder at making good choices, but it's possible to do. Okay. The other thing we do is we talk about cognitive restructuring. And for anyone who's done CBT in the past, you've probably heard a lot about this, but this is about changing your negative thoughts about exercise and nutrition. So, for example, I hear a lot, oh, Dr. Sylvia, I'll never be able to exercise. I've never exercised in the past. I've never been able to do it. I'll never lose weight. I've never been able to lose weight. I don't have the time to exercise. I'm too tired to exercise. Healthy foods are too expensive. So these are all thoughts that can be obstacles to leading a healthy lifestyle, right? If you're thinking those things, it's difficult then to make healthy choices and to, eat well and exercise. So therefore we do what's called cognitive restructuring, and there's some great books out there on that. One I love is Mind Over Mood by Greenberger and Podasky. There's also a great book called Cognitive Therapy by Judy Beck that talks a lot about cognitive restructuring, but it's helping people to overcome those negative thoughts and changing them in such a way that they may be more helpful for you. And that takes time and a lot of effort, but once you work at that and work on changing those thoughts, it will absolutely help you to overcome those obstacles and help you to make healthier choices. The other thing that we do is in this intervention is we make very specific food diaries. So if you've ever signed up for any weight loss intervention, from Weight Watchers to, I don't know, any of those other commercial weight loss programs out there, they probably all asked you to track what you're eating, right? Well, that's not anything that we're doing differently here. Same thing goes here. We do want to know what you're eating every week, and so we do ask that at least 4 out of every 7 days you write down what you're eating. Now that can be a burdensome task. I get that. So what we try to do is we start simply. We just write down like what you're eating, very generally, turkey sandwich, a Diet Coke, an orange, whatever it is. And then several weeks later, we build up. We start saying, okay, what was in that turkey sandwich? And how many oranges did you have? And how big was the orange? And then several weeks later, we ask you to actually assign calories to each of those kinds of foods. Now, the good news is that there's some very good applications out there on the internet and for your phone that will actually, if you enter in, one small orange, the calories will automatically pop up for that. So I really encourage you, if you are thinking about trying to make some changes to your lifestyle habits, to think about doing a food diary and think about how technology may help you. One website I like is calorieking.com, and they have just a nice food diary there that you can enter in. You can log in, enter all your foods in there, and again, the calories will pop up for you, so you don't have to look up all the different calories of all the different foods that you're having. Okay, so, but that's very important to do that, and unfortunately, it's kind of a key part to really, we call this self-monitoring. Self-monitoring is a very important part to actually being aware of what you're eating and making the necessary changes to eat healthier. And then we also use sort of the typical CBT session structure. So again, as cognitive behavioral therapists, we like to sort of structure the session. So we talk about having a specific agenda for that day. We go through what the overview is, but we also do a check-in to make sure that we tailor that session to how you're feeling that day, as well as to what else might be going on in your life. Maybe you're going to, I can remember someone coming in and saying, no, Dr. Sylvia, I'm going to Italy for 2 weeks, and I, love my wine, and I love my food, and I love Italian food. So we had to kind of really focus that session on how to try and eat healthy and make good choices while in Italy. So that check-in allows us to sort of tailor that session to what might be going on in your life at that time. And then we work together to set homework. And, you know, I wish I had sort of the magic cure to helping people live healthier. But at the end of the day, I always tell folks, I usually meet with people for 45 to 60 minutes a week. And the other 6 days and 23 hours, you're on your own making these choices. So there really has to be some practice between sessions. And that's what homework is. It's something that you're going to be working on between sessions to try and really incorporate some of the work that we are doing during the hour that we're meeting throughout the rest of the week. We also talk about what's called stress generation. So folks that have bipolar disorder tend to experience more stress. And we don't really know whether it's the chicken or the egg, if you will. So we don't know if it's because you have bipolar disorder, you're more likely to just perceive that you have more stress because you have this vulnerability to having a mood disorder. Or is it that folks that actually they have bipolar disorder as a result of having extra stress in their life? It's probably some combination of both. Right? So we probably think that folks with bipolar disorder, that part of the reason you're experiencing the disorder is because you do have a lot of actual stress in your life. But then there's also a part that you're probably perceiving some things as being more stressful than they actually are. So we talk about both those things, how to manage actual stresses in your life, but also how can we reduce your perception that something is maybe seems really awful. Like, for example, maybe somebody got in a car accident that day, a fender bender, or somebody came in, you know, I'm just trying to think, their television wasn't working, or, you know, these things that, you know, are kind of stressful things, and they might sort of make that a really big deal and really, really bother them for a long time. And so we do a lot of work around, like, what can we do about those things, and do we have to let those things kind of run our life or really generate a lot of stress for us? And that's how we kind of change a perception of stress. And then we, as I said, I sort of already mentioned this, we talk about the impact of currently what your mood state is. As you know, bipolar disorder, you may be feeling several different things at any given time. Most people are depressed about 80% of the time. You'll be experiencing depression if you have bipolar disorder, but you know, that depression can sometimes be overlaid with, you know, anxiety, irritability, a whole host of other things. So we always check in to sort of see how you're doing and then make mood-specific modifications. We absolutely work collaboratively. I would be silly if I didn't ask exactly what you know, the folks I'm working with wanted to do and where they were at. And last but not least, we do what's called a functional analysis, which is understanding. So let's say you went out to dinner last night and you had that dessert. One of your goals for the week was really to try to reduce your eating dessert. Well, what I would do is I would ask you, you know, what are all the things that led up to you having that dessert that night? And I might start even the day before. Maybe there was something stressful that happened the day before, the day you ate the dessert. And that's what kind of, you know, generated that stress, which then made you kind of want to reward yourself the following day. So that's what a chain analysis or a functional analysis is. It's taking a problem behavior, if you will, like eating a dessert or not exercising for a certain day, and going backwards to try and see all the things that may have led up to that decision point as to why you didn't exercise or why you decided to eat the dessert. Okay, and then we use rewards to try and create motivation for change. Okay. So I'm just going to walk through a bit of the evidence that I have so far. This is really, as I said, really, really early stuff, and I'm really just trying to give you a little bit of an idea of how we're testing this intervention. But I, again, would love to hear everyone's thoughts on the call today about ways that they would like to see this intervention improved or changed. So the first thing I did, I always kind of thought that doing a lifestyle intervention should be done in groups. It just seemed to make sense. You know, you get some support from groups. You know, a lot of the information that we're giving is pretty, I don't want to say by any means basic, but it's information that can be generalized for a large group of people. You know, a lot of what I've talked about so far as it relates to health and wellness. So we started off with having two groups, and we tried the intervention. Every week we asked people to record how much they were exercising. We also record everyone's weight. We also got food diaries, which I don't have listed here, but we also had everyone do food diaries every week. And then we did, at the beginning, the middle, and at the end of the treatment, we asked people how their symptoms were, both depressive and elevated symptoms, and then their overall illness severity, sort of overall, how are you feeling, and finally, how is your functioning? So how is your relationship with friends and family? How is your ability to go to work? How is your ability to do household chores, etc.? So we take bipolar 1 or 2 diagnosis. We do ask that you're currently symptomatic. So if you're really doing well, you know, and you had no depression or no elevated symptoms, you would not be eligible for the study, only because I wanted to see if this intervention helped with people's symptoms. So in order to see that, I have to make sure that people have some symptoms when they come into the study. We asked, I work in the adult bipolar clinic, which is why we're doing ages 18 plus, although I absolutely think that we need to come up with some interventions for our pediatric sample as well. And then we took everybody who was overweight or had a BMI of 25 and above. And then folks who were excluded were people who had, so the PAR-Q is a physical activity readiness questionnaire. So if there was some reason that your doctor didn't think that you were able to exercise, and we unfortunately couldn't let those people into our study, if you were abusing or dependent on substances or had an eating disorder, that didn't make you eligible. And if you were currently exercising regularly or had any reason why you couldn't make diet or exercise changes, we also excluded those individuals as well. So very, very, very small, small group here. We just had 4 people, but the good news is that we saw a very good effect in terms of the weekly exercise. And we saw changes, positive changes in just about every single outcome, but nothing was really significant because it was such a small group. So one of the feedback, though, from doing these small groups was we decided we needed to shorten the nutrition module because that was too much nutrition stuff, but actually increase the exercise module. People really wanted more focus on exercise. And so new treatment in the very beginning was actually shorter. It was only 14 sessions over 16 weeks. Now, as I'm doing the randomized trial, it's longer because one of the feedbacks from this earlier work was to keep making it longer. We included more skills. We did more goal setting as a group. People in the group setting really liked having the group accountability. So they liked coming in and sort of reporting back to the group in terms of how they did and what they struggled with and getting some group impact on that, some group feedback on that rather. And we also did more motivational interviewing techniques. And that's really, motivational interviewing is really about increasing what I call intrinsic motivation to do things. So sort of your personal motivation. A lot of people try and do healthy lifestyles because, again, they want to fit into that dress, or they want somebody else to think they're attractive, or, you know, they just want to, you know, do it for their friend. But really it has to come from inside you. Like, what are your reasons for making these changes? So that's motivational interviewing sort of helps to do that. So we did the second pilot study, which was doing another group intervention. And so we had that first group with 4 people. Then we did those modifications, and this was the second group that I ran. Now you'll start to see that we are seeing that column with the p-values there. If it's smaller than 0.05, that means it's technically a statistically significant improvement. So that was good. We did see some improvements in the right direction for things like weight and waist circumference. Those all obviously got better from pre-treatment to post-treatment. Again, we saw great effect with the weekly exercise. And overall, the CGI going from a 3.5, so you want to go down in these last columns because you want to, higher scores means worse functioning and more symptoms. So everybody had better overall illness, fewer depressive symptoms, but interesting, and fewer manic symptoms, and improved functioning. So again, going to a 9.3 means that you actually had better functioning. So again, we saw everything in the right direction from our second group, which was good. But again, I asked for more feedback, and from the second group, and people said, make it longer, make it longer. So we added 4 more sessions. So that's how we got to our 18 sessions over 20 weeks. We included more CBT skills. We did more goal setting. We added more motivational interviewing. I train now my therapists do a lot more motivational interviewing as part of the therapy. And otherwise, it was the same intervention, but now what was interesting was we applied for funding to the National Institute of Mental Health, and I got what's called a K-23. It's a Career Development Award to now do this intervention as an individual opposed to a group intervention. And the reason we did that was for a variety of different reasons. One is from a scientific perspective, it's very difficult to test a group intervention for its therapist integrity, for its efficacy, and as it relates to outcomes. And it's very hard to control for that. So we did the individual. The other reason we did the individual, though, is that one of the pieces of feedback I got from the groups was that they really wanted more individualized feedback. So for instance, we had some folks in our groups who really, they didn't necessarily want to lose weight. They really wanted to focus on nutrition and were very interested in vitamins and minerals. And therefore, I didn't necessarily have enough time to focus on that for those people. Or again, the wellness module was very challenging because I couldn't individualize it as much as I wanted to because, again, it was a group intervention. So we did decide to do it as an individual. And that's where we get to our next and again, we integrated more motivational interviewing. And here's just an overview of motivational interviewing. I won't go too much into this, but again, the goal of motivational interviewing is just to get people to sort of really make changes for themselves, this sort of enhancing intrinsic motivation piece. So a lot of reflective listening and positive affirmations to help people come to wanting to make changes for themselves opposed to anybody else. All right, so now I have the funding from NIMH. When we're now doing an individual, we're now doing new treatment as an individual therapy. We use the same measures and eligibility that we did at the outset from the, so again, bipolar 1 and 2, overweight, same exact criteria. Very, very small study, just 5 people for this open phase trial before we started the randomized phase. Okay, there's some demographic information there. So from these 5 people, we had so I should say we consented 7, 2 participants were ineligible and 0 dropped out. So out of the 7 that we consented, 5 stayed in and made it all the way through. We had pretty good feasibility as it related to the intervention, as almost everybody attended all the sessions, or 90% of the study visits were attended, which was great because, again, it's a long intervention. It's 18 sessions over 20 weeks. And 76%, I was impressed with this percentage because we actually had 1 or 2 people who really struggled with their food diaries who brought the average down. So most of the people, it was actually 1 person who really struggled with the food diaries, and the other 4 did almost 80% to 90% complete the food diaries every single week. So, but that's, I put that in there because that's a challenging thing to do. And so I want people to think about, what was the adherence rate to doing the food diaries. There was a really good acceptability score for the intervention. So I got a 46 out of a 50, which is basically means that people really liked the intervention. And same for the overall care satisfaction. So again, a top score of 32 means they just loved the intervention, and we had a mean of 31. So the intervention was also seemed to be, people liked it and seemed to tolerate it well, and so that was good. So out of, again, this very small sample of 5 people, you'll see that I didn't really get, I'll be honest, the outcomes I was hoping for with this study. So we only, with this small group before going to the randomized trial, we only got a weight loss of a couple pounds, which wasn't ideal. Again, we saw great effect with exercise. This continues to be one of the biggest things that new treatment does, is improves people's exercise rates. So you can look at the number of days and exercise duration there, really increased, threefold here. And then all the other symptoms kind of went in the right direction again. Again, was the CGI went down as expected, depressive symptoms went down, mania symptoms went up slightly, but to be honest, this is such a minor, having 4 or 5 on the mania scale is almost no manic symptoms. So really, there's almost no clinical difference between a 4 or 5. Essentially, we had, out of the 5 people in the study, almost none of them had mania coming into the study or throughout the study. And so therefore, we just didn't see any change in that. And the life rift is a great reduction. Going from a 12 to a 9 is a really good reduction in the life rift. All right. And so we also, for this study, finally analyzed the food diaries. And again, what was interesting about this is one of the first studies, I should say. In this study, we just published in the International Journal of Bipolar Disorders. And I think we got it in that journal because this is one of the first studies that really looked at and analyzed. Now, granted, it's only 5 people, but we really got to look at what people were eating. And we did a very good analysis of this. Now, you'll see at baseline, or at the beginning of the study, people aren't eating too badly. People that came into the study were having, 1.5 servings of fruit. We'd like to see that to be more like 2 servings. People are having slightly over 2 servings a day of vegetables. I'd like to see that probably closer to 3, but not terrible. Grains, we asked people to eat between 6 and 7 servings of grains. That was good. Meats, we asked people to eat about 5.5 servings, so a little bit under. Dairy, the USDA suggests having 1 to 2 servings a day. The Harvard folks kind of say you don't have to have dairy, but either way, 1.77. pretty good in terms of the dairy. You'll see the sugars. The sugars are pretty high, 108 grams of sugars. That's, you know, that's certainly on the high side. But again, the overall calories isn't too bad. Now, again, this is, you know, here the mean is cutting across both females and males. So that could be a little bit high for females, but it would actually be a little bit low for males. So overall, that's, you know, not too bad at all. So, you know, I didn't see a lot of improvements here, as many improvements as I would have liked at 20 weeks. And I think it was in large part because the people who came into the study happened to be fairly healthy. And I think this is because the people who came into the study I recruited from Patient Family Day at Mass General, and I think they were a fairly healthy bunch to begin with. So, you know, but this is interesting. It goes to show that, you know, A, it's certainly possible to eat fairly well if you have bipolar disorder, and 2, suggests that there may be a certain population that's doing well and other folks that may be struggling more, and we need to make sure that we target those people, because this was just a really small sample. We certainly can't generalize from this. But the take home of this work was that people were not exercising, but their diets are fairly good. Diet and exercise interventions people tended to like. So far, all this pilot work that I've done had been well received by the folks who had done it. There seems to be promising evidence that people can create healthier lifestyles of bipolar disorder. Again, that outcome with the exercise was great. People really, really improved their exercise. That was fabulous. And changes in diet and exercise do seem to be associated with improvements in depression, overall functioning, as shown by those improvements in the MADRS and the Life Risk scores. Lots of study limitations. The biggest one, obviously, the 2 big ones here, the sample size was very, very small, and as I already mentioned, they were recruited mostly from MGH Patient Family Day, so maybe folks who were already very involved with their health and wellness. I was the only therapist for all the studies up until now, and we had no blinded raters or control groups. So with that, we start thinking about what we did for our randomized control trial, our RCT. We made a few more minor changes to the manual before starting the RCT. We included celebrations of rewards. That's from the Diabetes and Prevention Project, the DPP. A few more tips on eating out. We included some stuff on the importance of fiber, the importance of reducing sugar-sweetened beverages. We also required that we get a DEXA scan, which gives us an understanding of how much body fat somebody has. So we looked for people who weren't just overweight, but also had at least 30% body fat. And now the therapists are no longer me, but I was now training the therapists who were doctoral clinical psychology students to do the intervention. So we started this last fall, so that's why we're currently doing the RCT, and after the RCT, we'll do another modification to the manual. So again, I hope that those of you on the call today will give me some thoughts about what we can do to improve this manual. And I hope to finish recruitment sometime next year. And again, that's when we'll be revamping the manual. Same measures that you've seen before, and same inclusion-exclusion criteria, with the exception of doing the DEXA scan. And here's our current status. So as of March 1st, we've consented 18, randomized 14. We've had 1 dropout. We've actually had 2 completers now, and so the rest are active. So we have 11 active people. So that's it. This is my collaborators and who I call my fearless research assistants, all the people who've been working very hard behind the scenes to actually make this study work. And if you are interested in hearing more about it, you can call Emily Bernstein, who's my research coordinator. Her phone number is there. You can also email me. And I'm also doing a totally self-promotion here on my book that I wrote with 2 of my colleagues, Stephanie and Noreen. If you have bipolar 2 disorder or know anybody that has bipolar 2 disorder, please pick that up. We think it's pretty good, but I'd love to know your thoughts. So with that, I will wrap up and see if there's any questions or comments from the group.
Thank you very much for your talk, Dr. Sylvia. I do have a question. First question is, has it been measured how processed food, fast food, might be associated with negative outcomes for people living with bipolar disorder?
Was fast food? Was that the question?
Yes, processed and fast food.
Yeah. So the only person who's really looked at that I know of is Amy Kilborn, Dr. Amy Kilborn. She works out at the University of Michigan, VA, and she did a very good study looking at what she called prepackaged and processed foods. I don't necessarily know if it was fast foods per se. We'd have to go back and look at her study, but her last name is Kilbourne, and it's spelled Killbourne. If you search her name, you'll find this paper that I'm talking about. It's the only one that I know of, and basically just shows that folks with bipolar disorder are at increased risk for eating those foods than people who don't have bipolar disorder. But we don't really know exactly the outcomes. But we can imagine. I just was going through. I have somebody right now who I'm working with who loves some of the restaurants here that we have in the States, like Boloco. I don't know if anybody knows that restaurant. It's sort of a burrito fast food joint. And obviously you've got your Wendy's. We're also looking at Subway. These are all sort of fast food places. And I was pretty astonished, I have to say, by how high in sodium and saturated fats a lot of these foods have. It's particularly Boloco, which is this, as I said, this kind of burrito place. So we haven't done the data as far as I know, we haven't done the research well enough yet to know exactly what the outcome is, but we can pretty much guess that it's not going to be great, because a lot of these foods, it's unbelievable how much they can hide in these foods with sort of bad ingredients and things like that. I wouldn't think a burrito could possibly be as bad as it could be, but when I go out to Boloco and look up the nutritional information, it's really pretty bad. So same with Wendy's, we looked up their chicken filet sandwiches, and I really encourage you. The good news is all of these restaurants now have the nutritional information online, like Dunkin' Donuts does. They have a lot of hidden things. Be careful with them. Same with Starbucks and all their drinks. You've probably heard about how those drinks can have a lot of sugar and things packed in them. So although we don't know exactly the outcome, we know that these restaurants can be problematic, and certainly we suspect have pretty bad outcomes.
Great, thank you. Next question. What about the impact of grains on bipolar? Some doctors have suggested that gluten sensitivity can be a problem.
Great question. And yes, I have heard that. I have somebody I'm working with right now who is doing a gluten-free diet because of that. She also has irritable bowel syndrome, IBS, and so she's been really trying to make that change. We don't really know. It's something that we think may be helpful, but I always tell folks it's tough to start with that. So I tell people to first start with the Harvard Food Plate. Like, start with your basics. Eat your naked foods. Have your fruits and your vegetables. Try to stick with whole grains opposed to the refined grains, and stick with what I call healthy proteins. So, lower fat proteins, even the 90% red meat opposed to the 80% red meat that you get at the market, because gluten-free can be challenging. If you're somebody that is struggling already to have a healthy diet, trying to make it gluten-free can be really tough. It can be expensive and can be tough. If you are eating very healthy already and you're still having some issues and you want to try gluten-free, talk with your doctor first, but there is some thought that might have a positive outcome.
Great, thank you. I think that's it for the questions today. If you have any additional questions, you can email me, and I'd be happy to forward those on to Dr. Sylvia. I just want to say thank you so much for your time and all of your information that you have shared with us today. We very much appreciate it.
Excellent. Thank you all. If you have any questions, please reach out to me. I'm at the Master General Hospital Bipolar Clinic. I'm happy to answer any other questions as well. Thank you very much.
Thank you.
All right, take care.